Good morning to all of you. So I'm sure this neurology topics have been discussed earlier with you in one of the sessions earlier. So today I would be not going into any theory part of it. We'll be just discussing few questions. And as we discuss the questions, we may take up any doubts or clear any doubts which you have. So the topics which we would be covering in my next 1 hour would be all this status epilepticus, acute stroke, subarachnoid hemorrhage, meningitis, encephalitis, cerebral protection methods, brain dead, Guillain-Barré syndrome, myasthenia gravis, and neuromuscular disorders. I've tried to take at least 1 or 2 questions from each. So I have a set of 15 questions which would be discussing the questions followed by the answer. So I want this group to be interactive so that we have something. Even if you do not want to speak out, at least type in the chat box. We'll be having A type and K type questions. There'll be 10 A types and 5 K type questions. So the first question: all the drugs are used in the management of status epilepticus except diazepam, carbamazepine, thiopentane sodium, and phenytoin. I need an interactive group so that I can answer there.
Participants, I'd request you all to kindly use the chat box to answer. Dr. Thakur has replied with the option 2.
Okay. Anyone else? So yes, the answer is carbamazepine. Okay. So like for explanation, we know diazepam, thiopentane sodium, phenytoin, all are anti-epileptics. So can you name few other more anti-epileptics which are being used for status epilepticus? The drugs which are being used for status epilepticus?
Yeah, it can be also the phenylketonuria, and it can be also the...
Yes, very true. So we have these drugs which are being used. We have the benzodiazepines, we have the clonazepam, phenobarb, as rightly mentioned by Dr. Morsi. We have thiopentane sodium, propofol, midazolam. So these are the last 3 are used for refractory cases of status epilepticus. Okay. So this is a list of the drugs which are used. So if we say what is the first line of treatment for status epilepticus?
Benzodiazepine.
Yes, along with anti-epileptic phenytoin. Okay, if no other contraindications are there. Next question. A patient with Guillain-Barré syndrome is admitted in your ICU. See, why we are discussing this question, so that you have an idea of what are the question bank, what are the questions you may ask, you may be asked during your exam. So when we are discussing about seizure, the question which is related to seizure mostly are from the drugs. So that's why I've given one pattern question. So when you're reading the theory part, give focus to that. Okay. The patient with Guillain-Barré syndrome is admitted in your ICU and is on mechanical ventilator. The staff nurse on duty informs you about the sudden increase in the heart rate to about 140 per minute. You order a 12-lead ECG which shows sinus tachycardia. The following are true about the cardiac manifestations in GBS except sinus tachycardia is the most common manifestation and usually does not require treatment. True or false? Serious life-threatening bradyarrhythmias require immediate administration of atropine and cardiac pacing if required. The hypotension in Guillain-Barré syndrome is usually due to dysautonomia and can be managed with fluid boluses and low-dose phenylephrine. Intraarterial blood pressure monitoring should be initiated for wide fluctuations in blood pressure. Arrhythmias other than sinus tachycardia are very rare in Guillain-Barré syndrome, and if present is usually because of intrinsic cardiac disease. So what happens in GBS? What do you think? What happens in GBS? So basically in GBS, there is some autonomic dysfunction, right? Because this is a disorder of the nerve, so there is some dysautonomia. There might be some arrhythmias, right? So what do you think is the answer here? The question says the following is true except. Yes, Dr. Morsi, you have texted 5. Everyone else, do you agree to that? Dr. Thakur, you have texted 1. Sinus tachycardia is the most common manifestation and usually does not require treatment. Don't we get sinus tachycardia in patients with GBS? So the answer is arrhythmias other than sinus tachycardia are very rare in GBS, and if present, it is because of the intrinsic cardiac disease. No, arrhythmias are quite common in GBS, and it is because of the dysautonomia in the patient. There is some autonomic disturbance in the patients of GBS, that's why. Sinus tachycardia is one of the most common manifestation, and patient, if there is sinus tachycardia without any hemodynamic instability, usually does not require any treatment. We just have to treat the cause. We need to treat the GBS, and automatically it will get corrected. So we see sinus tachycardia. We can see any variety of arrhythmias, be it sinus tachycardia, be it bradyarrhythmias, tachyarrhythmias, but sinus tachycardia is the most common manifestation seen in GBS. Okay, so there is, as I've said, there's lot of dysautonomia. So this may be, the arrhythmias may be present. Okay, and when a patient is having arrhythmias, for close monitoring of these patients in ICU, patient is having hypertension, intra-arterial line is indicated and should be given, and which this hypertension may be managed by small doses of vasopressor agents. Okay, next question. A 50-year-old male with complaints of fever, neck stiffness, and altered sensorium. LP and MRI was done, which showed suspicious of viral encephalitis. Which of the following is true except? 𝑨𝒄𝒂𝒓𝒂𝒕𝒐𝒓 will need to be given empirically as soon as possible, while however we'll wait for the CSF results. Vidarabin 15 mg per kg per day is an alternative to acyclovir. Vidarabin is more effective than acyclovir. Vidarabin and acyclovir are of no benefit in non-herpetic encephalitis cases. One question was from Dr. Thakur, that is there any test for autonomic dysfunction? No, there is no test. To diagnose GBS, we do a nerve conduction study or the electromyography. That's the only test. We do a CSF to see for any protein cell differentiation. For any test for autonomic dysfunction is not there. We only monitor the patient closely for any arrhythmias, for any hemodynamic instability, and manage accordingly. If we can treat when the patient returns back, when the porta and the sensitive part have come back, slowly these arrhythmias get settled. Okay, we do not need immediate any antiarrhythmic drugs to counter these arrhythmias unless and until patient is having severe hemodynamic instability associated with the arrhythmias. Okay. So yes, the answer is 3. Acyclovir should be started immediately as soon as we suspect viral encephalitis till we get the CSF confirmation of herpes simplex. Acyclovir should be given empirically if the CSF is negative for herpes simplex. It should be stopped. There are many other antivirals which have been used, and vidarabin is one of it. But it is, acyclovir is always said to be more effective than vidarabin. There is no such studies or literature which have shown that vidarabin is more effective than acyclovir. Clear? Then regarding here, when we talk about the encephalitis, role of steroids. Any comments?
Steroid can be initiated in case of encephalitis secondary to, I think, TB.
Yes,
and
true.
There was association of retroviral medication, HIV patient also. It should be associated with some.
Sure. Right. So for this steroids, the things has been very clear now. It has been clearly mentioned in a textbook and in literatures that use of steroids is there, especially as Dr. Morsi have rightly said in TBM. In viral encephalitis and bacterial meningitis, use of it is limited to short duration. Earlier in our practice, we were giving steroids for long duration, maybe 7 to even 14 days we had continued, but now it is just limited to 3 days. Okay. MRI features of viral encephalitis. You may get different presentations of in MRI. For example, in Japanese encephalitis, the most commonly involved area are the thalamic areas, the basal ganglia areas. We see hypodensities there in the MRI. In herpes simplex encephalitis, the most commonly area involved is the temporal area. We get hypodensities or lesions seen in the temporal area. So MRI itself may be suggestive of the type of viral encephalitis, which type it is. So if we have confirmed reports of MRI, we can go up to a diagnosis before even can we get the CSF reports. Okay, Dr. Thakur, is it clear? Go to the next question. 40-year-old homosexual, a drug addict, presented with altered sensorium and fever. The patient family gives a history of weight loss, repeated lower respiratory tract infections, repeated skin infections. So, what do you think will be the most common organism responsible for meningitis in this patient? Yes. Cryptococcus neoformis, because that is the most common, because in a retrovirus patient, patients have a high chances of opportunistic infection. So this is one of the most common infections seen in a retropositive patient causing meningitis. Okay.